This lecture covers the relationship between lab values and hemodynamics. The definition of hemodynamics is the measurement of blood pressure in the vessels or the heart chambers during a contraction and during relaxation. So systole and diastole. The physiology of blood pressure, there are three factors that will determine what your blood pressure is. It's either going to be the pump itself, which is the heart, and the pump creates a pressure, so it can be a factor on whether that pressure is increased or decreased. The blood, which is the fluid in the pump, and the amount of fluid available to circulate throughout the system. And then the blood vessels that pump and blood. Pump has to send the blood through the vessels. And the diameter of the vessels is what actually will affect the blood pressure. So for the heart, if the rate or strength of the pump increases, then so does your blood pressure. If the rate or the strength of the pump decreases, then so will your blood pressure. With blood, if you have more fluids available in the same diameter, then your blood pressure will increase. If you have smaller amount of fluid available, then your pressure will decrease. And as far as the vessel diameter goes, if a vessel is constricted, it increases blood pressure. If it's dilated, it decreases blood pressure. So all of this should have been a review for you because we talked about it in cardio A&P. Last but not least, there's a note here: a change in hemodynamic measurements reveals a change in one of these three factors. So not all of them have to be happening at the same time. If one change happens, then you will see a change in the blood pressure. So to monitor the movement of blood, which is what hemodynamic means, you have to have an indwelling catheter in place, and that catheter tip is what is going to measure directly the movement of blood in that area. And it will be attached to a transducer, which that transmits the signals to an oscilloscope, which will show the waveform, and the monitor, which will show the actual value, the numeric value. There are three types of catheters: central venous, pulmonary artery, and arterial catheters, and we'll talk about these a little more in the rest of this lecture. But for the central venous catheters, they measure central venous pressures, and this is considered your right ventricular preload. For pulmonary artery catheters, it measures your pulmonary artery pressures, and we consider that the right ventricular afterload. And the pulmonary capillary wedge pressures are also measured by the pulmonary artery catheters when you inflate the cuff, and that gives you your left ventricular preload. Lastly, the arterial catheters measure systemic pressures, and those values should be very close to the manual blood pressure reading because the manual blood pressure reading tells you what's going on with systemic pressures, just like the arterial catheters do. So as we go along in this lecture, we'll break down the difference between central venous, pulmonary artery, and arterial in the course, rather, not in this lecture. In this lecture, we're going to talk more about how you monitor changes in pressure. So with these particular monitor systems that have an indwelling catheter, you have to have a closed system that is also filled with liquid to mimic what's actually going on in the body. So the pressure that is exerted at one point can be measured accurately at any point on the same level. So if a catheter is placed into the radial artery facing the flow of blood, then connected directly to a tubing that is also filled with liquid, then the pressure that is exerted by the blood at the tip of the catheter in the body will be accurately transmitted to the fluid-filled tubing. And then this pressure is then changed to an electronic signal by the transducer and amplified and displayed on the monitor as both a waveform and a digital readout. And that's important because that waveform should correlate with the digital readout. And if it does not, it lets you know that something is going on with the monitoring system that you have in place. Now, to ensure that accurate measurements are being displayed on the oscilloscope and the monitor, the transducer and the catheter have to be at the same level. So the transducer, catheter, and it says measurement site, and the measurement site is nothing but the catheter tip. So they should all be at the same level, and that's just to offset the force of gravity. So for example, if the transducer is located lower than the catheter tip, then your readings on the monitor are going to be higher than what's really going on in the body. And we'll talk more about some of these errors that can occur to affect the accuracy of the system. Okay, so potential complications, just because you're going inside the body, there's always going to be complications with invasive procedures. So these are the 5 potential complications with putting in any of these indwelling catheters: infection, dysrhythmia, bleeding, trauma to the blood vessels, and blood clots. Now, I already mentioned that the 3 types of catheters are arterial catheters, central venous catheters, and pulmonary artery catheters. But what you need to know here is in a clinical setting, they're going to call a pulmonary artery catheter a Swan's-Ganz catheter. Okay, so as a clinician, you should be very concerned about lab values. You should be looking in the chart, looking at the lab values that the patient has received. And the ones that we're concerned mostly about are urine output, urinalysis, chemistry panel, complete blood count, and coagulation studies. For the chemistry panel, it can also be called a basic metabolic panel. For urine output, we want to either directly measure it or indirectly measure it. When we directly measure urine output, or fluid output, we're talking about urine and vomit. Indirectly, we can tell what's going on with a patient's output by looking at their respiratory rate, so their lungs, because you do have to humidify the gases that come into your system. So you are losing fluid when you breathe. And then your skin, if the patient is diaphoretic, then that is also an indirect measurement of their output. Normal urine output is 40 cc's an hour. So if output decreases, but you do not change the patient's intake, then they will get fluid overloaded. So if you're taking in the normal amount, but you're not getting rid of it, then that means you're keeping it inside. And the things that the patient will present with in that case is weight gain, electrolyte imbalance, increase in hemodynamic pressures, and decrease in your lung compliance. That's important for a vent patient. When they have decreased output, then it's going to affect their lung compliance. If output increases and you don't change the intake, then dehydration may ensue. So weight loss, electrolyte imbalance, decrease in hemodynamic pressures, and vasoconstriction are all things that you may see when a patient has an increase in how much they are diuresing. Okay, when we test the urine, we do what's called a urinalysis, and that is just a screen for the metabolic status and kidney function. We really are utilizing this to determine what things is the body trying to excrete because of the metabolic status, and also what things is it trying to excrete because the kidneys are not functioning properly. So the things that we look at with the urinalysis, basically the patient's going to pee in a cup, or we're going to collect their urine some kind of way. We're going to look at the appearance. The appearance should be a light straw yellow color. The darker the color, the more indication that something's going on with the kidney. Specific gravity is the weight. pH, of course, you know what pH is. Glucose, the kidney should not be permeable to sugar molecules. So increase of that is bad. Ketones is kidneys, bilirubin is liver, and sedimentation is just the think particles that are settling in the urine. As I mentioned earlier, chemistry panel can be CMP or BMP. It measures the electrolytes, potassium, sodium, chloride, and bicarb, and in that order. Sodium is most important, but potassium is most important, but potassium, sodium, and chloride are all a part of your cardiac function. So the clinical application of getting a CMP is if your patient is presenting with muscle weakness, soreness, nausea, mental changes like being lethargic, dizzy, drowsiness. All of those are factors, signs and symptoms that you may need to get a chemistry level and that they may have some type of electrolyte imbalance. So we're going to talk about each one of these individually. Also with the chem panel, that's going to be collected in a red top tube or a speckled top tube, sometimes green, but mostly red and speckled top. Potassium, of course, is signified as a K plus. So the normal range is 3.5 to 5.0 milliequivalents per liter. It puts me in remembrance of the CO2, which is 35 to 45, right? Even though this has a decimal, 3.5 to 5.0, it's very close to your CO2. So the way I remember potassium is it's like my CO2 just with decimals. So hyperkalemia means you have too much of the base. And on the ECG rhythm, it's going to show a spike T wave. And this obviously signifies metabolic acidosis. And if you have hypokalemia, it reveals flattened T waves and may signify excess excretion, metabolic alkalosis, and vomiting. Normal range is for sodium is 135 to 145. It puts me in the mind of pH, 7.35 to 7.45 milliequivalents per liter. Hypernatremia may signify dehydration, and sodium is also retained in exchange for potassium. So when you have a patient who is losing potassium, they will hold on to sodium. So hypernatremia could show signs of dehydration. So they're diuresing that potassium out, and therefore the body is holding on to sodium. Hyponatremia may signify either fluid loss from diuretics, vomiting and diarrhea, or fluid gain from CHF and IV therapy. So it's hard to tell with hyponatremia what's really the patient's issue, whether they have too much fluid or not enough fluid. So they have to give you more in the scenario. So if they give you in the scenario that the patient's been vomiting, has diarrhea, or is on some type of diuretic, then you know that the hyponatremia is due to fluid loss. And then if they mention CHF or IV therapy, then you know it's fluid gain. Chloride is another part of the CMP or basic metabolic panel. The range is 85 to 100 milliequivalents per liter, and I associate that with the PO2, which is 80 to 100. You know, the MBRC doesn't do anything close, so if you remembered 80 to 100, you would not be off. So with hypochloremia, it means you don't have enough chloride, and that may signify metabolic acidosis. And if you have hyperchloremia, it may signify metabolic alkalosis. Bicarb, you know about bicarb. I am not going to bore you with bicarb other than this little bit that it states here, which is referring to increased bicarb signifies metabolic alkalosis, and decreased bicarb signifies metabolic acidosis. You should already know that. The first bullet mentions that CO2 is carried in the blood as bicarb, because you know CO2 bonds with water and does the carbonic anhydrase stuff. So you already know about bicarb, so we're going to move on to complete blood count. Your CBC is your complete blood count. That is collected in a purple top tube, and it has EDTA as the anticoagulant in the tube, and that's important that it needs to have that because you don't want this blood to clot. And the CBC collects your red blood cell, hemoglobin, hematocrit, and white blood cells. And your RBCs, hemoglobin, and hematocrit all increase or decrease at the same rate. Red blood cells is the normal range is 4 to 6 million per cubic millimeters, and it increases due to polycythemia. Polycythemia means that you have an increased red blood cell count due to tissue hypoxia. And anemia is when you have a decreased amount of red blood cells, and this may signify blood loss or hemorrhage. Hemoglobin, the normal range is 12 to 16 grams per 100 milliliters of blood, or grams per deciliter, and it may also be presented as 14 plus or minus 2. If it goes up, polycythemia. If it goes down, anemia. Hematocrit is nothing but a percentage. What percentage of the red blood cells is hemoglobin? Normal is 40 to 50, and if hematocrit increases, then that's polycythemia. If hematocrit decreases, that's anemia. So red blood cells, hemoglobin, and hematocrit all increase or decrease at the same rate. White blood cell count, your WBCs. White blood cells are also called leukocytes. Don't get that confused with lymphocytes. Leukocytes means white blood cell, and lymphocyte is a type of white blood cell. So the normal range is 5 to 10 or 5,000 to 10,000 per cubic millimeter. Depends on what your facility uses. If it's listed as 5 to 10, then it will be per 1,000 cubic millimeters. If it's not listed that way, it'll be 5,000 to 10,000. Increased white blood cells, the term for that is leukocytosis, and this may signify bacterial infection. If you have decreased white blood cells, this may signify a viral infection, and we call that leukopenia. There are 5 main types of white blood cells: neutrophils, lymphocytes, monocytes, eosinophils, and basophils. The way I remember that is never let monkeys eat bananas. So never for the N in neutrophils, let for the L in lymphocytes, monkeys for the M in monocytes, eat for the E in eosinophils, and bananas the B for basophils. Neutrophils is 64% of the white blood cells available. If you add the bands and the sex together, you get 64%. Lymphocytes is 30%, monocytes is 3%, eosinophils is 2%, and basophils is 1%. MBRC loves to make sure that you know that the white blood cell that increases when someone has some type of allergic reaction, like an asthmatic patient, the white blood cell count that's going to increase is the eosinophils. Creatinine and BUN are all both lab values that will indicate whether something is going on with the kidneys. And creatinine, not creatine, creatinine is excreted by the kidneys, and it evaluates kidney function. The normal range is 0.7 to 1.3 milligrams per deciliter, and you do need to know the units. BUN, blood urea nitrogen, evaluates kidney function, normal range 8 to 25. Coagulation studies. Any coagulation study that is collected in a blood tube will be in a blue top tube. The series of tests that quantify clotting mechanisms of the body. Coag studies are always performed for patients that are pre-op. Very important because they want to know before they cut on you whether you are at risk for hemorrhaging. Evaluation of bleeding signs and symptoms. The patient seems like they're bleeding internally or just bleeding for whatever reason. They can do a coag study. Diagnosed for DIC, that's when patients are literally bleeding when their stool, they have bloody stool. That's what I'm trying to say. And also to monitor anticoagulation therapy. If a patient is on an anticoagulant, they will do a coagulation study. And we're going to talk about these tests on the next slide. Clotting time test is the first coag study we'll discuss. It is measured by puncturing the skin. They take a lancet on the forearm, punctures the skin, makes a little slit on the skin. Skin starts to create little blood It'll either literally start flowing of blood or just a little bubble. And they take a circular litmus paper to collect the blood that's coming out until it clots. If it takes less than 6 minutes, then you're good. If it takes longer than 6 minutes, then you're not ready to have surgery. You're not forming clots properly. Platelet count, it's very important for forming clots because it's a part of the clotting process. Normal range is 150,000 to 400,000 per millimeters cubed. Decreased values are associated with decreased bone marrow function. So that's important for patients who has problems creating red blood cells as well. Your APTT is another coagulation study, and it measures the length of time required for a plasma to actually form a clot. The normal range is 24 to 32 seconds. The MBRC loves to know if you know that APTT is used for monitoring heparin therapy. Your PTT and TT are the last two tests that we will discuss. And your PTT, or prothrombin time, the normal range is 12 to 15 seconds. That should remind you of hemoglobin. And it is used for monitoring warfarin or Coumadin therapy. And the thrombin time, which is the TT, the normal range is 7 to 12 seconds. So in this lecture, you should have gained knowledge of the lab tests that you should be looking at while you are evaluating and assessing your patient, and also the intro or overview of hemodynamic monitoring.